Hello, everyone. My name is Sarah Medeiros. I am a clinical pharmacy specialist practicing in malignant hematology as well as stem cell transplant at Baptist Cancer Center. Today, I'll be discussing the Fast Five stories from this past year in malignant hematology, and these are various updates that I've selected from ASH, ASCO, NCCN, and beyond. First, I'll just highlight some of the objectives. We'll be investigating the new EPKINLY indication in follicular lymphoma and evaluate associated primary literature. We'll be discussing Scemblix or asciminib for the treatment of newly diagnosed chronic myeloid leukemia or CML. We'll also be evaluating data regarding blinatumomab or Blincyto in minimal residual disease negative acute lymphoblastic leukemia. We'll also be reviewing some primary literature regarding the addition of Darzalex or daratumumab to first-line treatment for patients with newly diagnosed multiple myeloma who are eligible for autologous stem cell transplant. And last but not least, we'll be discussing agents that are used for the treatment of acute myeloid leukemia that are currently in the oncology pipeline. Approved. So on June 6th of this year, the FDA approved a new indication for an accelerated approval for epcoritamab or EPKINLY for the treatment of relapsed or refractory follicular lymphoma after 2 lines of therapy. This was based on the EPCOR NHL-1 trial, which we will discuss more in the following slides. But first, I think I would be doing a great disservice to you all if I did not highlight some of the pharmacology of EPKINLY. So EPKINLY is a bispecific T-cell engager, and it works by essentially linking or activating T-cells, which then attack the tumor cell through the binding of CD20 on B cells to the CD3 on T cells. The way I think of this and the way it helped me remember the mechanism of action of these drugs when I was in residency is that it's essentially like Tinder for T cells. The CD20 and CD3 are brought together through EPKINLY. The dosing schedule is also a little bit different for this new indication compared to dosing for other B-cell lymphomas. So EPKINLY is still given subcutaneously and in 28-day cycles. However, there is an additional step-up dose that you can see here on day 15, and this is step-up dose 3. And we'll discuss why this was added with some of the data from the clinical trial. Next, we'll look at some supportive care pearls. So all patients in cycle 1 should receive a steroid pre-medication, with dexamethasone being the preferred agent. Dexamethasone is given on day 1 and then for 3 consecutive days following each weekly dose. In addition, patients should also receive Benadryl and Tylenol prior to each dose in cycle 1. Pre-meds in cycle 2 and onward depend on how the patient tolerated cycle 1. So if a patient experienced a grade 2 or higher CRS episode with a previous dose, then they should continue to receive dexamethasone with subsequent cycles. And that's in addition to the 3 subsequent days of dexamethasone, so 4 days total. And they should continue receiving dexamethasone until they receive EPKINLY without an episode of subsequent CRS. And you might be thinking to yourself, with the other indication for EPKINLY, do they require or encourage hospitalization? And the answer is actually no. And we'll discuss why this is with some of the clinical trial data. So EPCOR NHL-1 was an open label, multi-cohort, multi-center, single-arm trial. And the one cohort that we're going to be focusing on today specifically looked at follicular lymphoma. It included 127 patients with relapsed or refractory follicular lymphoma, and this was defined as at least 2 or more lines of preceding therapy. These patients were assessed for primary efficacy with overall response rate and duration of response, as well as safety. One cohort received a 2-step-up dosing regimen, which is what we see in the other B-cell lymphomas. And then the other received a 3-step-up dosing. And that cohort included 86 patients who received that new recommended 3-step-up dosing schedule to help mitigate the risk of CRS. 82% of patients achieved the primary endpoint of overall response rate, with 60% of those patients achieving a complete response. Most importantly, and one thing that I thought was really interesting about this study is there were no grade 3 or grade 4 CRS events in this trial. Majority of CRS events were grade 1, and they occurred during the first cycle, with most of those occurring after the final step-up dose on day 22. The median time to onset of CRS across all the doses was approximately 60 hours, and CRS episodes resolved in every single patient. The results of this study led to EPKINLY being added as another third-line option for relapsed or refractory follicular lymphoma. Hot off the press. This next study was published in the New England Journal of Medicine on September 12th of this year. So we'll be discussing asciminib, also known as Scemblix, for the treatment of newly diagnosed chronic myeloid leukemia. So why Scemblix in the first line, you may be thinking, and that's a great question, especially since we know Scemblix is typically reserved for patients who have a very specific mutation in the chronic phase of CML called T315I mutation. It's also indicated in the chronic phase CML with patients who have resistance or intolerance to at least 2 prior tyrosine kinase inhibitors. And currently, it's not recommended as a first-line option. Most patients who are newly diagnosed with CML are treated with one of 4 TKIs, so imatinib, nilotinib, dasatinib, or bosutinib. However, these are dirty drugs and have many side effects. And as a result, many patients are unable to tolerate these medications and end up switching therapy within the first year of treatment. So Scemblix was specifically designed to enhance efficacy while improving safety compared to the earlier generations of TKIs. And this is specifically through its mechanism. It allosterically binds to the BCR-ABL kinase, and it's different from other ABL kinase inhibitors because it binds to this specific portion called the, I'm going to butcher this, mysterate binding complex, rather than targeting multiple different kinases. So this specificity means that Scemblix is unlikely to have off-target activity and thus less toxicities. So this trial was a phase 3 open label multi-center trial, and patients were randomized 1-to-1 to either receive Scemblix or an investigator selected TKI. Randomization was stratified based on the TKI that was selected, as well as the baseline long-term survival score category. The primary endpoint was major molecular response at week 48. After a median follow-up time of 1.5 years, the number of patients who achieved a major molecular response at week 48 was significantly higher in the Scemblix arm. However, it should be noted that this trial was not powered to enable a comparison of the primary outcome between Scemblix and the second-generation TKIs. Therefore, whether Scemblix is more efficacious than the second-generation TKIs is not entirely clear yet and should be investigated further with more clinical trials. In addition, adverse effects that were grade 3 or higher were lower in the Scemblix arm, and it should also be noted that thrombotic events were low overall in the study in general. There was no difference between the groups. However, longer follow-up is needed to confirm safety. All in all, the results of this trial are a cautionary tale. Additional follow-up is needed in order to determine determine and understand the durability of response, survival outcomes, as well as long-term safety data. NCCN update. So nothing yet. However, it may be worth noting that Scemblix doesn't have any major drug interactions like the other TKIs that you can see here. So the usual suspects that you think of here with proton pump inhibitors, antacids, antidepressants, and various cardiovascular medications. So it may be worth considering this as an option in a patient, say, on amiodarone who can't be switched from this medication. Other than this very niche circumstance, it probably should be reserved for later lines of therapy unless we have more data that comes out later. Next, we're going to discuss Blincyto and some ECOG 1910 data updates. It seems like the more we learn about Blincyto, the more benefits are observed. We know that many older adults with ALL can relapse despite having MRD negative disease with combination chemo alone. And based on the preliminary results of the ECOG 1910 study, we know that the addition of Blincyto assists with deepening these remissions in this previously difficult to treat patient population. This study included over 500 patients with Philadelphia chromosome negative B-ALL between the ages of 30 and 70 years of age. And of these patients, 224 achieved a complete remission with MRD negative disease after induction and intensification chemotherapy. And these were based on pediatric inspired regimens, which I have displayed here on the right. This study was a phase 3 randomized trial and had 2 treatment arms. So after induction with 2 cycles of chemotherapy, MRD was assessed at the end of intensification and after count recovery. And patients who had less than 0.1%, or excuse me, 0.01% leukemic cells in the marrow were considered MRD negative, and then were randomized to either receive 4 cycles of Blincyto with 4 cycles of consolidation chemo, or just 4 cycles of consolidation chemotherapy alone. And I could probably talk about the nuances of this treatment used in the study, but this portion that's blocked off here is the major takeaway of the 2 arms, if you need to see a visual. Primary outcome was overall survival, with secondary outcomes being relapse-free survival as well as safety. So Blincyto added to chemotherapy significantly improved overall survival at 3 years compared to just chemotherapy alone. A benefit was also seen with relapse-free survival at 3 years. However, not surprisingly, more neurologic or psychiatric adverse events were observed in the Blincyto arm. There are some limitations to this trial that elicit further questions that I have for future studies to answer. So one being a substantial portion of patients who were enrolled in the study actually didn't end up undergoing randomization. And this was due to a variety of reasons, anywhere from relapse of disease, toxicities, death, and interesting enough, a large portion of these patients actually ended up proceeding to allogeneic stem cell transplant. The authors of this study also tried to mitigate the last reason by stratifying patients based on if the treating physician was planning to take their patient to transplant or not. But it's also not clear whether even earlier treatment with Blincyto would be beneficial in this patient population. And here is the NCCN update. I put update here in quotes because we know that the ECOG 1910 protocol has been added to the guidelines for ALL since mid last year. There's not any delineations yet on MRD positive versus MRD negative. Blincyto is recommended for MRD positive, but there's not any updates on MRD negative disease. Next, we'll discuss the addition of Darzalex to treatment of newly diagnosed multiple myeloma in patients who are eligible for autologous stem cell transplantation. So I like to think of myeloma treatment as a puzzle, and you have different puzzle pieces that fit into a complete treatment. You have your immunomodulatory medications like lenalidomide or Revlimid, a steroid backbone with dexamethasone, a proteasome inhibitor with bortezomib or Velcade, and then the addition of anti-CD38 monoclonal antibody, Darzalex or daratumumab, which we'll talk about further. In July of this year, the FDA approved Darzalex for the treatment of newly diagnosed transplant-eligible multiple myeloma patients. And this was the Perseus trial. The Perseus trial was a phase 3 randomized open-label study, and it included approximately 700 patients with newly diagnosed multiple myeloma. The patients in this trial were randomized 1-to-1 to either receive 4-drug treatment with the addition of daratumumab to Velcade, Revlimid, and dexamethasone. And this was followed by Darzalex and Revlimid maintenance after transplant, or they were stratified, randomized to receive the standard of care Velcade, Revlimid, and Dex, followed by Revlimid after transplant. The primary endpoints for the study were efficacy and progression-free survival being the surrogate endpoint, as well as safety outcomes. So to probably nobody's surprise, 4 drugs were found to be superior to 3. The 4-drug regimen with the addition of Darzalex was found to have a statistically significant improvement in progression-free survival at the 48-month follow-up. However, serious adverse effects were observed more often in the Darzalex arm, but interestingly enough, this did not lead to more therapy discontinuation, which was actually higher in the 3-drug regimen, so the VRD arm of the trial. And so the authors concluded that the addition of Darzalex to treatment with VRD induction had a significant progression-free survival benefit in patients with multiple myeloma who are transplant eligible. And this page of the guidelines was extensively revised with the last update, but VRD is currently listed as an other recommended regimen in the guidelines, but should be considered in patients who may have high-risk mutations or a higher risk disease. Last, but certainly not least, we're going to be talking about what's next in AML. For the sake of time, we'll only focus on CAR T and menin inhibitors. So menin inhibitors, I feel like this is the next upcoming thing in AML as well as CAR T therapy. So KMT2A and NPM1 are driver mutations and occur in approximately 10% of patients with AML. These mutations are associated with a higher incidence of relapse and a poorer prognosis. And so the 2 that I was able to find, I'm sure there's many more, but these 2 are specifically beyond the phase 1 study trial period, so they're moving on to phase 2 and phase 3, is SNDX 5613 and KO 539. And there's even some trials that are looking at the combination of menin inhibitors with other treatment modalities that are found to have a synergistic effect. So one example I was able to find is the ECROS, which its mechanism is depicted here on the right in the diagram. So CAR T and AML, finding the right target. We know in B-cell malignancies, CD19 has been the bullseye target for CAR T. Likewise, with multiple myeloma, BCMA-directed CAR T has been the magic target. However, it's like finding a needle in the haystack. There's still one yet to be found in AML. However, there are some that are still being investigated currently. Identifying target antigens that are exclusively expressed on AML blasts is a challenge. And in order to avoid myelotoxic effects resulting from target antigen expression on healthy cells. So some targets that are currently under investigation include CD123 and CD33. You might be thinking this sounds familiar, and that's because gemtuzumab works on this target, as well as CLL1. Another topic in this field has been autologous CAR T or an off-the-shelf option with an allogeneic CAR T product, and both are currently being investigated in clinical trials. Another challenge is reducing CAR T toxicity. So long-term toxicities include prolonged pancytopenias and increased risk for infections. And this can be really tricky in patients with AML since we know these patients with AML are already at such a high risk for developing major infections. But other than that, that's all I have. So thank you for having me. If you have any questions, please feel free to reach out.